to really be able to create models that help with as a tool for prediction, you need high volume of data, which also, by the way, helps take out bias. You want variety of data, again, going to bias, and generally better machine learning models, and veracity, the truth of the data. So that's sort of the step one.
Data science and AI are transforming healthcare. That's Shez Partovi, the Chief Innovation and Strategy Officer at Royal Philips.
7 years ago, Philips decided to divest of everything other than healthcare, and is really now a health tech company. So while you may see Philips lighting still, it's really just a licensing. Philips itself is now a 100% health tech company focused on the continuum of care, everything from at home, ambulatory, inpatient, and so on. So when you think of Philips now, think of it as a health tech company. It's a 130-year-old startup because it really transformed itself 10 years ago. So it's like a startup that's 130 years old.
You're a physician. You're the Chief Innovation and Strategy Officer at Philips. So tell us about your role and the work that you do, where you're focused.
I have one of the best jobs in the world because I get to work on the strategy side. I get to work with customers and to understand their unmet needs and to work backwards from customer problems and then work with my colleagues to create a strategy that would have Philips solve those problems for our customers. So that's the strategy side. And then on the innovation side, when we listen to our customers and what problems they have, then we have to look and see, well, how do we innovate on their behalf to solve those problems? And so the entire innovation community inside Philips is part of my remit. And what we do is to listen to customer signals, look at the market trends, and then canvas technology that we have or that's external to Philips, and how to put that together to be able to delight the customer, in this case, whether it's a health system or whether it's a patient. That's the job, is to the nexus of listening to customers, getting the signals, creating a strategy, and then turning to the innovation teams and saying, how do we delight our customers inventively? How do we innovate on their behalf? And then go to market with those propositions. So that's the teams I lead, and it's just literally like a kid in a candy shop. It's the best place to be.
I know a lot of your work is focused on data. Can you shed some light on that aspect of it?
We have now in healthcare a lot of data creation, data generation. And of course, the cynics would say, well, yes, and most of that's used just for billing, particularly on the US lens. Notwithstanding that sort of perspective, it is still true that a vast majority of data is now digital. When you think of, for example, the classic clipboard that you would go in and fill stuff out, now you probably are filling stuff out online, which means there's digitalization of data. What's really so that has occurred, but when you look deeply, you find a few things, and I'll just mention them briefly, and then we can maybe talk about them, which is the mechanisms and processes of digitalization are not necessarily seamless and frictionless, meaning there's a lot of repetitive menial tasks. When folks talk about clinician burnout, physician, nursing burnout, is partly related to the fact that while we are digitally transforming, they're not necessarily in a frictionless way. They're not workflow aware and they're repetitive. So that's the process of digitizing is not optimal. Then having digitized and created data, again, notwithstanding the billing aspect, some would argue that we haven't made meaningful use of that data in a really amazing way. So we are perhaps data rich, but insight poor in healthcare. So A, we struggle in a friction-laden way to make the data, and B, sadly, we don't really create incredible insights from that data. So that's where we are sort of in healthcare from my lens.
What is it about healthcare that leads to these two fundamental issues that you just mentioned?
What we have is a couple of challenges, which is one, the data is generated is right now still much more application-centric, which means they're sitting in silos. And so while some organizations, I remember when I was in a health system, we had like 1,500 applications. So now you imagine you're digitizing data. It is in the application environment, but you have 1,500 of them. And so the absence of data liquidity means that while you have digitized and put the data on disk, you've not necessarily been able to combine that into an environment that then from which you can garner insights. And so this, because we're in this transition to digital forms, we are in a part of the world, part sort of the development of this, where it's a lot of isolated environments. And of course, as you know, there's a lot of work being done to bring all the data together into a common environment from which insights can be generated. So it's partly where we are, partly in this transformation, digital transformation, is they are siloed. And again, different countries are in different stages of either laying down regulations that say, yes, I get it, that's an application, but you must allow it to freely go back and forth because we want data to be the point of care. So some regulations happening. And of course, technology is also advancing. Philips has an environment called Health Suite, which is about data liquidity. It's about bringing in data from hundreds of different sources so that even though it's not the application tier, it's at this data liquidity tier that allows you to then go, okay, so I have the data, combine it, and then generate insights from it. So that's sort of where we are because of this part of the journey we're in. We are still fractionated, and a lot of health systems are struggling from the point of view of combining data into a common environment.
So the issue of data liquidity, that is fundamentally data sitting in applications that do not share that data. Is that correct?
It is. And data interoperability actually is really, you should think of two dimensions, which is there's syntactic interoperability, where you're just data sharing, and there's semantic interoperability, where there's the meaning of it is being shared as well. And so, yes, we're in this place where we have a lot of data silos, but then there's also great progress being made around interoperability, not where we want to be, but I don't want to pretend like no progress has been made. And now there's more and more interoperability happening, which is a precursor to now what? In other words, now that you, in some organizations, have generated liquidity, so there's a desire to go from data to information, from information to knowledge, from knowledge to insights. And so that's the journey that's AI enabled, of course, that we are in many places. We're on the sort of that journey in the precipice of getting to insights at scale.
And we have a very interesting question on LinkedIn on this very topic. And this is from Miles Sewer. I know Miles, he works a lot with chief information officers. And he asks this: so how do you move from being data rich, as you just described, to being data driven, meaning making use of that data?
For the audience, let's at least get a common framework of data and insight. Because it's a term used by a lot, and at least in this discussion, have an understanding. So I'll give an example of going from data to information, information to knowledge, and knowledge to insight. And the example I can give you is, let's start with a single data point, like a blood sugar value. And if you have a single blood sugar value of like 140 milligrams per deciliter, it's high. But on the other hand, is it because the person just had a meal? Is it a fasting blood sugar? Is it not fasting blood sugar? So that's a data point. Useful, but not insightful yet. And so if I give you, Michael, a trend of sugars that's going up, now I've given you information. The information is that this trend is going up, and you start to say, something's going on here. If then from there we look at the history and understand the patient may be pre-diabetic or diabetic, now you have knowledge of the patient's condition. But today, what health systems are asking for, what clinicians, physicians, nurses, organizations want in order to affect the quadruple aim in a positive way, improve quality, reduce cost, and improve experience, what they want isn't just data, information, or knowledge. They want to answer the following question: what is the likelihood that this patient whose blood sugar you showed me and is pre-diabetic, what is the likelihood they're going to have congestive heart failure in the next 18 months? What's the likelihood they're going to have diabetic foot ulcer in the next 2 years? This prediction, this insight into the future, this is the real opportunity when you bring data together and you're able to use that to build machine learning models and use AI. It's that looking into the future, the prediction model, that is really how you can use the data to drive the organization with insights. Because you will probably, as a clinician, as a physician, I'll give you this true example. There's a team we're working with in New Zealand where they were predicting the likelihood that a person would fill in the script upon discharge. And you have to ask yourself as a clinician, what would you do different if on the screen there's a prediction that says red, let's just use red, yellow, green, that the likelihood this individual is going to fill that script is red. In other words, they're not likely. And at that point, you may ask more questions. Are there social determinants of health issues? If there's other things versus green. Now, you may say, well, we should ask everyone. I get it. But it's this idea of the prediction and the triggering to the clinician to do something different that is the connection to what you in the question was the data driven. It's data driven because it gives you the insight that changes what you might do. So that's the thread: data to information, to knowledge, to insights, to some sort of actionable thing for me that I might do different in this case, in this patient, at this time, in this moment, at this point of service.
Now, be sure to subscribe to our newsletter. Hit the subscribe button at the top of our website so we can send you our newsletter. Subscribe to our YouTube channel. Can you now ground all of this in patient outcomes? You started alluding to that, but what is the consequence on patients of these silos? And what would be the advantage? What are the advantages if we have this kind of interoperability, first off?
I always bring everything back to the quadruple aim, which is how do you improve care quality? How do you reduce the cost of care? And how do you improve either the clinical experience for the clinician or the patient experience or the consumer experience? In a sense, improve quality, reduce cost, and improve the human experience, no matter who the human is. And so and that's the frame that we use at Philips, actually. Everything is in the frame of the quadruple aim. And let's just start with, for example, one that I think is perhaps even easier. Let's talk about, for example, how do you, in a health system, reduce cost? And one of the things that using AI with data can do is to help with what is termed really operational forecasting, which is, for example, what's the right size of the staff I need in my emergency department next Friday night? What's the patient flow? Can I predict the patient flow through my hospital so I can right size my staff, which, by the way, impacts care quality, because if you are understaffed, it's a challenge. And so right sizing is both a cost impact, a positive impact on cost, but also a positive impact on care quality. And so that idea, for example, using a ADT stream, admission discharge transfer stream, to build a model that provides prediction for patient flow through an organization, which is something that Philips does as an application, patient flow capacity. And so that's a model in which is a direct way in which you go from a very simple concept of a single data stream, ADT, in initial 7 data stream, to creating a prediction model that can help drive the way in which you actually run and staff your organization, which impacts the experience of the patient. It certainly impacts the experience of the clinician. If they're understaffed, it's difficult, and it impacts care quality. So operational forecasting is one category. So let's put that aside for a second. And I already alluded to this idea of clinical prediction. I used the example of the diabetic example, predicting diabetic foot ulcer or heart disease. And there are many instances of that that could be brought in. And so just to go a bit further, you could use, for example, clinical prediction if you're reading radiology films, you use that to look at films using AI ML to resort the way in which films are reviewed by the radiologist, because you're either identifying or predicting an anomaly, and you say, well, I think the algorithm says this film should be read sooner because there's going to be a care quality impact. If this prediction is real, this finding on the algorithm is real, then the radiologist should look at it and effectuate positive action. And so instead of reading it by the order in which the films were taken, or the CT scan was taken, or what have you, the algorithm re-ranks the film to the top. It's read first, care is delivered first, positive impact on patient outcome. So those are the ways in which, when you look at how do we use AI ML, AI and machine learning, to positively impact healthcare in using the quadruple aim concept, operational forecasting and clinical prediction are the two lenses that I use when I think of how do we at Philips help make a positive impact on individuals.
We have an interesting question from Twitter, and this is from Arsalan Khan, who's a regular listener. Thank you, Arsalan, for your great questions. And he says that a significant amount of data is held inside very few market-leading applications. So why would, and this is his term he's using, why would a monopoly have an incentive to share that data? So in other words, aren't the market forces of software essentially and and infrastructure, don't those militate against the kind of sharing that you're describing?
The data belongs to the health system as a proxy for patient care. And so the software companies actually don't own the data. For example, Philips doesn't own the data. We are stewards of the data for the organizations which we serve. And so in the United States, at least, there are now regulatory requirements that says you can't not share the information, and for the benefit of patient and society, you have to share it. I do know there are countries in the world, and I don't need to name them because I don't want to badmouth them, where the software companies actually own the data, and therefore that argument is true. So in US, at least, it's not trivial to say that I refuse to share the data. Information blocking rules would prohibit that.
Can you tell us the kinds of data that we need to be aggregating? I know, again, you've touched on it, but maybe drill into the data itself.
If you're thinking of AI and machine learning and clinical prediction, operational forecasting, you want to start from the problem and work backwards so that you know what data you need. Because if you think of it this way, Google Maps, if you remember, there's a time it just showed you the direction and the time, with the red heat maps. Then later on, it was, hey, here's how long it takes for a bike to go that path. Here's how long it takes for a human to go that path. Here's how long if you want to call an Uber for that path. And because based on the prediction and the value they want to deliver, they were gathering more and more data. So when you think of your organization, you have to work back from when you say, what data should we gather, Michael? It's a question, data is likely digitalized, but as you look at what data to bring together to create a model, you want to start from the problem and work backwards. So in the case of, let's say you say, I want to predict length of stay, because in our organization, it's really important to predict length of stay because we're trying to be a very agile and right-sized care and efficient. And we want to know length of stay because we will align our care services. If a patient comes in and our average length of stay is 3, if you can predict for me that this patient is likely going to be here 6 days, I want to put more resources on this. Why is that the case? How do I look and see what's going on? Why does it? So if length of stay is the question, then all you might need is ADT Street to predict length of stay. On the other hand, if you're trying to predict if a person has a particular disease or a particular cancer, you're going to need perhaps imaging, blood values, EHR data, electronic medical record data. So you want to start from the problem statement and the thing that you're trying to predict and the tool that you want to give to the clinician or to the operational teams, and then work backwards from that to see what data you need to be able to build that model that gives you that prediction.
And how do you make those decisions in terms of which problem to solve? Because in some cases, because you don't want to go down a rat hole where you try to solve a problem and it's not the right problem or you don't have the right type of data. So how do you make those decisions?
When we look at the way in which our customers are solving these problems, this is generally the way they go at it, which is you have either operational people that are trying to solve operation, and they literally, every organization has probably a lean team. I mean, that was really in fashion a while ago. Now, transformation teams, there are different names now for them, but they're all going around trying to solve. And then of course, there's clinical excellence teams as well. So you have, let's say, operational excellence teams and clinical excellence teams. I'm willing to wager your organization it might be called something different. And if you go to one of their steering committee meetings and sit there, they'll probably know the things they're trying to solve and the things that are scratching their head out. And I would say that's where you start from. And in fact, that's what our customers tell us. That's where they generally start from, is from those already teams, whether it's the chief nurse officer that's running a clinical excellence program, or the chief medical officer, or it's the COO, and she's running an operational lean program, excellence program. There are challenges they're trying to address. There is data upon which machine learning models can be built to help them as a tool to be able to address those problems. And so what I would say, and what I've seen be most effective in our customers, and if I were running if I was CMO for a health system, I would start from those places as opposed to saying what you and I might talking about now, which is, I wonder what we should solve. There are problems plenty. And you want to start from those that are already on your books, the ones you're already working on, and consider AI and ML, machine learning. And when I say ML, I just mean machine learning, AI, ML as a tool for those teams. That's it. It's not a whiz bang new fandang thing. It's a tool for the teams that are trying to either bring about clinical improvement or operational improvement. That's the best way to look at it, in my humble opinion.
In other words, solving the direct practical problems that you may face, whether it's on the clinical side or the operations side.
Absolutely. The simplest, and in fact, it probably aligns with the organization. I mean, I'm being practical now. Probably aligns with the organizational KPIs. It probably aligns with the team KPI. I mean, it really is a simple, straight place to start, is with those things.
Are the challenges of becoming a more data focused healthcare system that makes more effective use of the data, are these challenges primarily technology or process bias, operational aspects?
First and foremost, you of course need digital data. And with respect to data, there are the three V's, the volume, variety, and veracity. To really be able to create models that help with as a tool for prediction, you need high volume of data, which also, by the way, helps take out bias. You want variety of data, again, going to bias, and generally better machine learning models, and veracity, the truth of the data. So that's sort of the step one. Now, from the data itself, the steps include things, just to get technical here for a moment. You need to actually train a model. You need to label the data, which means this is what this data means. This is what it doesn't mean. It's generally as a human, this does the labeling. You label the data, you train the model, you have to validate the model. And depending on if you're going for FDA, sort of as for example, Philips, we're going for FDA review, we need to not only validate it, but meet certain requirements, do outcome studies, show that it does. Again, that's more of on the vendor side. Internally to help for operations, you wouldn't need to do that. So data, volume, variety, veracity, labeling, machine learning, modeling, testing and validation, and then possibly beyond that. So those activities are why generally, if your organization wants to do this, you probably want to partner with a health tech company, unless there may be some in the audience that are sophisticated academic medical centers that have affiliation with universities, that have folks that want to come help, or even have hired people that want to do this. So when you ask me what are the obstacles, it depends if you're implementing tools that perhaps you're getting from a Philips, or if you are wanting to build those tools and do it yourself. And in that case, you probably have a choice. You might partner with a health tech company that helps you, or some sort of a firm that does that. Or you might decide that you're really going to build an internal competency to do this. So that, to me, if someone stopped me and said, "Hey, Shez, I want to do this, what's going to be my biggest headwind?" I said, that's the biggest headwind. The tools are out there, but putting it all together is going to need competency, training, is upskilling. And so you either build it internally or you partner.
Makes sense. And I'm sure that there's also a very important team building and talent management aspect of this as well.
And then there is integration into workflow so that it's trivial, frictionless for the end user to use it. I would be remiss if I didn't say that, because it's not about tech, it's about workflow, it's about people and process more than about platform. So yes, I focus on the tech side a bit, but yes, without exception. And if you've done that, how do you get it into workflow in a point of care so that it's easy to use, it's frictionless, it's not this other thing over there, it's embedded. And again, that's where you either partner, you might buy something off the shelf that does all this, or if you're going to do it yourself, you have to think workflow.
Let me ask this question from Elizabeth Shaw, who says, how can an organization create this kind of enterprise-wide view into the data as it's coming from the various systems of record, from the different software vendors, essentially, different systems?
You want your data to be in an environment where it all comes together so that you can. So technologically, at the very least, you have to consider that you do need a holding area. What do you call it? Data lake, call it whatever you want to call it, a health data space. You need an area where you can have off ramps from the applications, ideally using standards like HL7, DICOM, FHIR, off ramps from the applications into a common area where it has those standard on ramps. And so you create this data environment. It's got the standard on-ramps, you have off-ramps, and you want to be able to stream that data. Not that you're moving, as I think the question I probably asked, not that you're moving all the application tier to this environment, but rather that you're off-ramp. You let the application do what it's got to do. It's a PACS application, great, do your work. If it's an EHR, great, do your work. You just need off-ramps that bring that data to an environment upon which, and the question used the term visualize, which I think is important. But if you remember, I went back and I said there's data, information, knowledge, and insight. Visualization is a term I would use for the data to information. So I said, hey, if you have a graph, and I often associate visualization with this idea of show me a dashboard and a graph. I think the more powerful thing, and it's likely what was implied in the question, is how do I create insights from that data, which is a higher order return on your investment than simple visualization. So I think you do need a data lake environment of some sort. And by the way, ideally in the cloud, because if you're going to run machine learning models, you don't want to buy expensive GPUs that's sitting in your data center idle 23 and a half hours a day and only for half hour running a GPU to do something. You want to use the cloud so that you pay for what you use the most sophisticated machine learning model training sets, training technology, and only pay for the part you use. Because if you're trying to build this in your own data center, you are going to overpay for stuff that you only use a fraction of the time. Don't do that.
I'll just tell you just my own personal quick story, which is I won't say the healthcare system that I use, but I stick with them. One of the reasons, there's a couple of reasons. They're great doctors and so forth, but there's also information lock-in, because they have a patient portal and it doesn't easily get tests or what have you, notes from doctors if I go outside their system. So there is this built-in gravity towards locking in the patient, which again kind of militates against the sharing that you're describing.
That's definitely difficult. I by no means did I suggest that it's easy. I'd say that a good example of an organization that's trying to do that, sort of, for example, broader beyond themselves, is UCSF. UCSF, and this is the public domain. We have a great partnership together, and using this common shared environment, which I referenced, they are actually bringing data from practices outside the UCSF environment and trying to create a holistic view that makes the movement of patients between practices trivial and easy, information sharing trivial and easy. So you're right. It's certainly not the default, the de facto default mechanism. On the other hand, if you ask me, Shez, how would you achieve that? It is going to be achieved through some sort of a common environment, a health data space where you're building in the cloud, allowing off-ramps. And I guess when I said off-ramps, in theory, it really is off-ramps, not just from your own applications. And in this case with UCSF, it's off-ramps from partner organizations in the community as well in the Bay Area.
Arslan Khan comes back with this question. He says he wants to know about who should be responsible if there's bad data, bad algorithms, and as a result, we make incorrect predictions. And so I think that gets right into the heart of some of the ethical issues that come up. So maybe you can tell us about that.
We continue at Philips to believe that this is a tool for a clinician to help in their decision-making, but that ultimately you want to have the clinician be the ultimate decider. So, and we can come back to this, but that's the first and foremost, philosophically, at least from our point of view, we're looking at how to create a tool that improves well-being, is transparent, is fair, and is a tool for the clinician for them to do their job, just as a blood test would be or any other test would be. And so there's this implicit connection where, and by the way, any test can have a false positive or a false negative, and clinicians through their training are synthesizing this and making a decision. So that which is different than, for example, the algorithm making a diagnosis on its own. We can talk about that if you wish, but that's different. There's a tool to a clinician. And then when it comes to bias, I come back to that comment I made earlier around the 3 V's of volume, variety, and veracity, and then validation, if you will. I guess that's the 4th V. And so definitely the process of creating algorithms includes this training with volume, variety, veracity, and then the validation. And in fact, it is, we all talk about, as clinicians, we talk about healthcare as local, which means is that a disease that's prevalent in one geography may not be prevalent in another. When I trained in both in Canada and the US. And I can tell you that a certain finding in chest x-ray in Canada was tuberculosis. The same finding in where I was training in the United States was coccidioidomycosis. They're different, but it was because healthcare is local. So algorithms need to be fine-tuned to the environment in which they're being deployed. There's not going to be one generic algorithm for the world, or let alone the United States. Healthcare is local. Training needs to be fine-tuned local. So these are the things, as you get deep into this, when you get past the hype and the media talk of algorithms will replace doctors, you begin to, as you unwrap this and really understand what these models are doing, you begin to understand that they are going to have to adhere to the same rules of, they are affected by the same things that affect healthcare. So algorithms have to be tuned locally as well. And then one last thing I'll say, because this topic is really near and dear to my heart, is that we are seeing a much more sophisticated absorption of AI and ML in customers, in health systems. And I'll give you an example. It was delightful to see one health system have a chief ethics officer. And we were working together on predicting no-shows to clinics. And this chief ethics officer was also in the sort of steering committee as we were talking about, and we can predict no-shows. And the question that came up in the room is, well, what do we do with that information? In the airline industry, if you're going to predict no-shows to an you double book the seat. And so that may have been the first thought. It was, well, let's just double book the appointment. Heck, we don't want to miss out on having a patient, because after all, you want to make sure you see people because it's care delivery and it's good for revenue, depending on the country. And then the question that came is, well, wait, why wouldn't they be showing? Could it be that they have scarcity and sufficiency? Maybe they don't have access to transportation. They need babysitter. And so then we realized that there might be an underserved an underlying principle that these individuals are underserved, that they're disenfranchised. And if the machine is predicting a no-show, that the answer isn't a double book. Because when you do, if they do show, the very people that actually need more one-on-one time get less one-on-one time because they're not double booked. So the answer may be, and they did, that you put together a team that when the machine learning model predicts a no-show, they call, they see what, how can we help? That's not they're calling to say, hey, my algorithm said you're not going to show, but Mrs. Jones, are you going to be coming? Mr. Jones, are you going to be coming? Do you need transportation? You need to get. So the very health system itself said, what do we do with this information that's ethically right? And we're seeing that maturity happening. And that's just beautiful to see.
You made a very provocative point around that the models need to be local, or reflect local conditions. Who is and who should be responsible for creating these models?
Algorithms can be fine-tuned, and systems are built, and that's how we do it as well. Systems are built to train them, to continue training as they're deployed. And so a model can be generically trained, using that term in quotes, and fine-tuned even in the background when deployed in an environment before it goes into production, and then continues training after deployment. So by definition, it becomes localized through its implementation and ongoing usage.
And are these models generally going to be supplied by software vendors, by healthcare systems, by companies like Philips? Who's going to be supplying these models?
All of the above. Certainly, Philips develops models, and we actually have an environment called AI Manager that you can put our models in that manager and use it. Organizations build models and can put an AI Manager and use it. So there are young companies that do it. I think he or she who has access to data can build models, good data. So I think all of the above. And we see a number of organizations, particularly academic medical centers, that are building models. And certainly a large number of companies are building models as well.
Did I understand you correctly that that local models is one pathway towards reducing the bias inside the models?
Yeah, it contributes to the reduction because the volume, variety, and veracity, you meet the variety criteria because you may have trained over here, and then when it goes local and it starts to get used, it's that the local variety tunes the model.
Where is all of this going over the next few years? And not 10 years out, but in a practical way, what's the trajectory?
Just as you have a bloodstream and you take a piece of blood, excuse me, I was going to say tissue, but you take some tissue, blood, and you run a test on it, there's going to be data streams that you take the data and run algorithms on it as a test. That's really the metaphor I'd use. Just as you have blood pumping and you take a test of that blood, you can have your data flowing through the veins and arteries of the health system, and you can take that data and apply algorithms to it. So clinicians will be ordering algorithms as tests. Yes, there's the background algorithms that always run, but some algorithms will be more heavy and may use a lot of compute, may actually eventually end up costing money because you're using compute to run them. And I think in the fullness of time, clinicians are going to order algorithms the same way they order tests.
What's the time frame that you anticipate for this?
I'd say we're probably looking at 5-10 years for some of the early indications of this.
Another question from, again, Elizabeth Shaw, who says, how can we ensure that data science is used to benefit patient care rather than just to boost profits? And at the same time, she also reminds us that technology is very expensive. And so how does that get factored in?
The lens through which one ought to look at AI ML in healthcare is how do you advance the quadruple aim? And quality, cost, and experience. So it's actually, cost is really 1/4 of the factor, if you 1/4 of the matter here. Workflow impacting, of course, clinician experience. We didn't talk much about patient experience, just a little bit. So it is important that all parts of the quadruple aim and organizations, and this is a call to us companies as well, that their focus should be on all aspects of the quadruple aim, not just cost reduction. I did comment earlier that if you're running operations more effectively, in my opinion, in cases, you are improving care delivery, because understaffing, for example, results in poor care quality. So they are tied. I don't want to make it sound like these pillars are separate, but the lens should always be the quadruple aim.
What advice do you have for healthcare administrators who are looking at this changing landscape? They know they need to adapt, but it's very tough for them because they're under such intense financial pressure, regulatory pressure, all kinds of different pressures.
I really do believe that in the early days, partnering with an organization, and I know this sounds self-serving because I'm Philips here, but I would do this if I was a CMO, because we talked about training, upskilling, we talked about the plethora of things that are required. It is not for the faint at heart. It is a heavy lift. Now, it gets easier. But my advice to administrators is that when you want to lean into this, is to explore the idea of having a tech partner and then working backwards from problems you're already trying to solve. Not, hey, what's a cool new thing we can do? Find a champion that's trying to solve a problem, bring in a tech partner, and see how can we apply AI ML with this partner to this problem. That's how I would do as an administrator.
What would you like policymakers to know about this changing world of healthcare?
I'd ask the question from, are you interested in the quadruple aim? Of course, rhetorical, because policymakers should and are, and that AI and ML has a significant role in advancing the quadruple aim. And so in my opinion, in this day and age, improving quality, reducing costs, and improving experience for patients and clinicians can be powered by AI ML. So policymakers should look at how they advance the adoption, removing barriers for AI and machine learning, because the net effect of that is what their other teams at CMS, for example, the US want to do, which is the quadruple aim. So they are tied together, and we should figure out how to advance those through policies.
And with that, I want to say a huge thank you to Dr. Shez Partovi. He is the Chief Innovation and Strategy Officer at Philips. Shez, thank you so much for taking time to be with us and sharing your knowledge with us today.
Oh, thanks so much, Michael. Thanks for having me on the show.
And everybody, thank you for watching, especially those folks who asked such great, amazing questions. I love you guys. You guys are such a great audience, and you're so smart, so intelligent. So be sure to subscribe to our newsletter. Hit the subscribe button at the top of our website so we can send you our newsletter. Subscribe to our YouTube channel. Everybody, have a great day. Check out CXOTalk.com for our upcoming shows, and we'll see you again next time. Take care. Bye-bye.